Dr. Ranjana Khanna ma'am with us and Dr. Sarita Valera has also joined in. Requesting Sarita madam to please introduce
My
Dr.
regards to
Ranjana
Dr.
Khanna.
Sarita. I missed you and the beginning, and Dr. Ranjana ji, namaste.
Hello, everybody. Yes, sorry I got a little late, but I was very happy to listen to Sir. And it was a wonderful talk. And I really think that magnesium sulfate has so much potential. But the difficult part is giving it through the infusion pump, giving those intramuscular injections, which are so painful. So I think that if we have this ready solution available, as you said, it will be a great advantage and we can really give it for both neuroprotection as well as eclampsia.
It is
I
available.
also think that we are delivering babies younger and younger now. And one thing is, okay, mortality, the neonatologists have taken care. But long-term morbidity is a big problem. And as we deliver babies more and more preterm, we really don't want to face this cerebral palsy problem, which is a disaster. Thank you very much, Pratik, for inviting me.
Yes, ma'am. Thank you so much for being here. Can I request you to please introduce Dr. Ranjana Khanna, our next speaker? Madam had some difficulty in logging in earlier.
Gives me great pleasure to introduce Dr. Ranjana Khanna. Do you have Madam CV?
Yes, ma'am, it's on screen.
Yeah. Oh, I can't see it. So it gives me great pleasure to introduce Dr. Ranjana Khanna. I've had the pleasure of working with her during her vice presidential year when I was secretary of FOXY, and we really did many things together. She's been the founder president of ISOPA Prayagraj. She's been the president of the Allahabad Society. She has given many prestigious talks and many prestigious orations. She's also received national awards like the Foxy Achiever Award, and she has been a faculty at many national, international conferences. She has delivered the prestigious Dr. Prabha Malhotra oration in 2023. And I have myself written articles and chapters with Madam and worked with her. So it gives me great pleasure to welcome Dr. Ranjana Khanna for the next talk.
Thank you so much, Sarita. Now, can I share my screen?
Yes, ma'am, please go.
They'll have to remove my CV. Is it okay? Is it visible?
Yes, ma'am, it's visible. You can go full screen.
I'll have to make it full screen. Okay. It is in full screen.
Not yet, ma'am.
Now?
Yes, ma'am. Now it is. Please go ahead.
At the outset, a big thank you to Dr. Pratik Tambe, and thank you so much, Sarita, for this very warm introduction. My topic is very interesting, actually. It's preventing preterm birth, role of progesterone, cervical cerclage, and pessary. Preterm labor is defined as onset of labor starting spontaneously after the gestation of viability and before 37 completed weeks of pregnancy. Threatened preterm labor is uterine contractions without any cervical change. Incidence: preterm labor accounts for 43.7% of all neonatal deaths in India. Less than 10% women diagnosed with preterm labor would actually deliver in the next 7 days. Of all the preterm births, 40 to 45 are spontaneous and 30 to 35 follow membrane rupture. Now, what is the pathophysiology? The cervix develops from the fusion and recanalization of the distal paramesonephric ducts, which is complete by 20 weeks of gestation and has both muscle and fibrous tissue. The fibrous tissue is responsible for the tensile strength of the cervix. Cervical insufficiency is related to a defect in the tensile strength at the cervicoisthmic junction. The risk of preterm delivery increases as the cervical length decreases. Hence, shorter the cervix, greater is the chance of preterm delivery. Short cervix is predictive of preterm birth. It's not diagnostic of cervical insufficiency, and many women with a congenitally short cervix would deliver normally at term. Now, what is the pathogenesis? previous history of preterm labor or late miscarriage is associated with 32% chance of recurrent PTB. 70% of the recurrent births occurs within 2 weeks of the gestational age of the prior preterm delivery. Cervical insufficiency could be there because of cervical surgery. Then lacerations during delivery, DNE, connective tissue disorders, ascending infections from the vagina and the cervix, which includes bacterial vaginosis, group B streptococcus, etc., systemic infections like pyelonephritis, pneumonia, acute appendicitis, and periodontal disease, uterine overdistension because of multifetal pregnancy, hydroamnios, causes stretching of the myometrium, initiates expressions of contraction-associated proteins. These are gene codes for gap junction proteins such as connexin 43, oxytocin receptor, and prostaglandin synthetase. They cause uterine contractions and cervical ripening. Feto-maternal stress is a very important reason for preterm labor. It causes elevation of cortisol in the mother, premature activation of the placental adrenal endocrine axis, causes increased placenta-derived corticotropin releasing hormone, increased estrogen level accelerates the cervical ripening and leads to loss of uterine quiescence. Then there could be medical factors and there could be PROM. Then uterine anomalies could be there, like uniconvate, biconvate, septate uterus, and other causes like low socioeconomic status, anxiety and stress, tobacco consumption, substance abuse, and coitus. Now, how can you predict preterm labor is about to happen? So it can be with fetal fibronectin levels, and of course, most importantly, by TVS ultrasound. So fetal fibronectin, it's an extracellular glycoprotein. It functions in intercellular addition during implantation and placental adherence to the uterine decidua. It is normally present in the cervicovaginal secretion up to 20 to 22 weeks of gestation. Around 22 weeks, the chorion fuses completely with the underlying decidua, which prevents the fibronectin to leak into the vaginal secretions. It is not detectable between 24 to 34 weeks of gestation, though it does not have a high positive predictive value, but it has a very high negative predictive value of 99.2%. So if it is not there in the vaginal secretions, you can be quite assured that the patient is not in preterm labor. Now, coming to the transvaginal scanning, funneling of the cervix with changes in the forms T, Y, V, U. See, this is learned by a mnemonic, trust your vaginal ultrasound. So in the T, you have just the opening of the internal os, and then it goes on to the funneling of the cervical canal till finally it opens and the external os is about to open in this picture. Cervical length less than 25 millimeter is quite indicative that the patient could be going into preterm labor, protrusion of membranes and presence of fetal parts in the cervix or vagina. Now, for treatment, the simplest way to effective surgery, just choose the right patient to do your surgery. So coming to McDonald stitch, that is the most commonly used transvaginal cerclage. First performed in 1963 by using a permanent suture. In this, we take with the Babcock forceps, we grasp the anterior lip of the cervix and take purse string sutures to try to take it as high as possible in the anterior part, and then just take a purse string and tie it tightly. The knot should be tied tightly and it is placed anteriorly. So this is removed either at the onset of labor pains or at 37 weeks. Then we have a high cervical cerclage Shirodkar stitch, which was reported in 1955 by Dr. V. Shirodkar, an Indian obstetrician. Many modifications of this has been made in the original technique. He used a strip of fascia lata, 1/4 inch wide and 4.5 inch long, which he removed from the outer aspect of the thigh. And to both sides, there was linen suture attached. So this is put on a Mayo's needle. Nowadays, we are using Mercillian tape. So In this, we make a transverse nick anteriorly, push the bladder up so that we can go as high as the internal os, and then with the Mayo's needle, or something like an aneurysm needle. Initially, it was known as Shirotka's needle, and we take a stitch which goes from the anterior to the posterior, and posteriorly we have a vertical nick. So we take it out from there, and then again from posterior to anterior, and tie a knot over there. And this is very effective in actually in cases of prevention of preterm labor. Now, what are the guidelines, RCOG guidelines regarding cervical cerclage? So there could be a history indicated cerclage should be offered to women with 3 or more previous preterm births and or second trimester losses. This is a level B evidence, should not be routinely offered to women with 2 or fewer losses. So please remember that if there are lesser losses, we don't need to give a cerclage. USG indicated cerclage is not recommended in women without a history of spontaneous preterm delivery who have an incidentally identified short cervix of 25 mm. So if you accidentally find it and there's no history of prior preterm labor, you need not give a cerclage. A history of 1 or more spontaneous mid-trimester losses or preterm births who are undergoing TVS surveillance of cervical length should be offered cerclage only if the cervical length is 25 mm or less before 24 weeks of gestation. This is a level A evidence. And ultrasound indicated cerclage is not recommended for mere funneling of the cervix if the cervical length is more than 25 mm. So coming to the serial sonographic surveillance, women with a history of spontaneous preterm delivery can be offered serial sonographic surveillance because those who experience cervical shortening are at an increased risk of subsequent mid-trimester loss or preterm labor and may benefit from cerclage very unlike those whose cervix remains long. But women should be informed that if you're not able to do a sonographic surveillance, then you can actually just wait and watch. Transabdominal cerclage is normally done in those patients in which the transvaginal fails. Rescue cerclage. Now, this is a very difficult condition in which the patient has already gone in preterm labor. We need a senior obstetrician for this. And normally what the internal os is already open, the external os is also open, and you can sometimes see the membranes also bulging. So what is done is that the patient is placed in the extreme Tredelenburg position with the head end low, and then we pass a Foley's bulb inside through the os, and then we gradually inflate it. So when you are inflating the bulb, the membranes, bag of membranes is gently pushed out from the view. And then we can apply the McDonald stitch, but be very careful while applying that gradually deflate the Foley's. Otherwise, you'll end up pricking that and including that in your suture. So, but in this case, if the dilatation of the cervix is more than 4 centimeters or the membrane prolapse is beyond the external os, and this appears to be associated with a high chance of cerclage failure. In multiple pregnancies and uterine anomalies, cerclage is not routinely recommended. So what are the contraindications? Active preterm labor, clinical evidence of chorioamnionitis, continuing vaginal bleeding, PPROM, evidence of fetal compromise, lethal fetal defect or fetal death. Complications would be membrane rupture, preterm labor, hemorrhage or infection. These are, however, uncommon with prophylactic cerclage. There is no role of perioperative antimicrobial prophylaxis and procolysis. Now coming to the next part, the cervical pessaries. Most commonly used is Arabin. This is very frequently used, but in India also we've started using. And others that have been used are ring pessary, Hodge and donut. The mode of action is that it presses the internal os closed from behind, changes the inclination of the cervical canal, so the uterus becomes anteverted and is gravid uterus. All the weight falls on the anterior segment and it is not there on the cervical canal now. And it protects the cervical mucus plug, thereby preventing ascending infection. Arabian pessary is round, cone-shaped, flexible silicone pessary, dome-shaped, resembles the vaginal fornices, hence it encircles the cervix. Has perforations in the silicone for drainage of vaginal discharge. Comes in different sizes. It has to be lubricated, squeezed between thumb and finger, and the smaller part goes in front, and then you go and completely encircle the cervix. So something like this it fits in. So the Arabian pessary goes right inside and it encompasses the whole cervix inside that. So it is clamping on the cervix. It's absolutely atraumatic, and the removal can be done very simply. So it unfolds inside with the smaller inner ring facing towards the cervix. The dome is pushed towards the fornices until the cervix is completely surrounded. Cervix should protrude through the inner ring. And it is removed at 37 weeks, or if the delivery is imminent, if contractions are effective, cervix is pushed back through the inner ring and the Arabian pessary comes out easily. The results of the pessary, several studies have been done, and they say that the results are quite good. Advantages: it is non-invasive, no anesthesia is required, there's no foreign body inside the uterus, reduced risk of infection, no effect of tearing of cervical tissues by contraction, no pressure necrosis of tissues under the suture, changes the uterocervical angle. So direct pressure is on the anterior segment, as I've told you, that the uterus falls anteriorly. So prevents direct pressure on the membranes, protects the cervical mucus plug, so less chances of ascending infection, may be left in situ in case of rupture of membranes on conservative management. Very easy to remove. Now coming to what we are doing in our daily practice, vaginal progesterone. Progesterone, we know, has an essential role in maintaining pregnancy, primarily through establishing uterine quiescence. This is achieved through suppression of the calcium, carmodium, myosin light chain kinase system, reducing the calcium flux and altering the resting potential of the smooth muscles. So what is the mechanism of action? It acts at various sites. So at the placenta, it regulates the timing of labor via controlling the stress hormone. In amniotic fluid, it limits the prostaglandin production. At the fetal membrane, it blocks the pro-inflammatory cytokines, induced apoptosis, preventing PROM. At myometrium and cervix, it suppresses the inflammatory response. Which progesterone? We all are familiar. There's oral progesterone, sustained release 300 milligram tablet. Then there are the pessaries, the soft tablets which we have. Then we have the gel. Injections are there, 17-alpha-hydroxyprogesterone caproate, and which is given weekly, and injection, natural micronized progesterone, which is given every third day. What are the international guidelines? French guidelines 2016 say that if the cervical length is less than 25 mm, it's undilated os. Then vaginal progesterone, either 90 milligrams gel or 200 milligram pessary, and duration 24 weeks to 34 weeks. It's level A evidence. And FIGO 2015 guidelines are practically the same till 34 weeks. And Strategy 2015, they recommend giving the vaginal progesterone till 37 weeks. ACOG says vaginal or intramuscular progesterone from 16 to 34 weeks, and SOGC is also of the same opinion. So with vaginal progesterone 2015, we can use it for prophylaxis of preterm birth. This is updated data of 2019. It is offered to patients with history of prior preterm birth less than 34 weeks and mid-trimester losses, and or results of TVS at 16 to 24 weeks of gestation shows a short cervix. Now, Society for Maternal Fetal Medicine 2017 said that in a woman with a singleton gestation and a history of prior spontaneous preterm birth between 20 and 36 weeks of gestation, we recommend 17-alpha-hydroxyprogesterone caproate starting at 16 to 20 weeks till 36 weeks of gestation or delivery, and vaginal progesterone should not be considered a substitute for this in these patients. Now, when we talk about twin gestation, Vaginal progesterone decreases preterm birth and neonatal morbidity and mortality in women with a twin gestation and a short cervix. An updated meta-analysis of individual patient data was done, and the conclusion was that administration of vaginal progesterone to asymptomatic women with a twin gestation and a sonographically short cervix in the mid-trimester reduces the risk of preterm birth occurring at less than 30 to 35 weeks of gestation, neonatal mortality, and some measures of neonatal morbidity without any demonstrable deleterious effects on childhood neurodevelopment. This was published in 2017, and it's a US government work. So, the use of progesterone for prevention of preterm labor. Vaginal progesterone and cerclage are equally effective for preventing preterm birth and improving perinatal outcomes in women with a singleton gestation with previous spontaneous preterm birth. The choice of treatment will depend on adverse events and cost effectiveness of intervention and patient and physician preference. A randomized trial of oral micronized progesterone, 400 milligrams OD for prevention of recurrent spontaneous preterm birth showed a trend towards reduction with increase in maternal serum progesterone levels. Now, progesterone as an alternative to cervical cerclage, an Indian experience. Pregnancy outcome in short cervix was done, progesterone versus cervical cerclage. So 50 patients were taken, 25 were kept on vaginal progesterone and 25 were applied cerclage. Now, what was the result? Conclusion was that NMP is as effective as cervical cerclage in prevention of premature labor in a woman with singleton pregnancy with a short cervix. Use of NMP is preferred because it is non-invasive, easy to administer, patients do not suffer from surgical and anesthesia-related adverse effects, and it is not associated with any hospital stay, very economical, so it's good for both the doctors and the patients. Dafoniska in 2003 did a study, 142 women with prior preterm births and or prophylactic cervical cerclage, uterine malformations. They were given 100 milligram progesterone suppository with a blind placebo trial. The same investigators in 2007 studied 413 women with a short cervix and gave 200 milligram progesterone suppository. They found a significant reduction in the preterm birth in the progesterone group. No RCT, however, has directly compared head-on vaginal progesterone and cervical cerclage in cervical insufficiency. 4 studies evaluated vaginal progesterone versus placebo, and 5 studies evaluated cerclage versus no cerclage, and they showed a statistically significant reduction in the risk of preterm birth. Eferivic et al. In 2013 compared 2 cohorts of women with previous preterm births and a short cervix. 142 women with cerclage, 59 women with vaginal progesterone. They found no significant difference in terms of perinatal loss, neonatal morbidity or preterm birth, but there was a higher rate of birth before 34 weeks in the vaginal progesterone group as compared to the cerclage group. So now what are the FIGO guidelines? They say that sonographic cervical length measurement should be performed in all pregnant patients 19 to 23 weeks of gestation by TVS at the same time as level 2 scan is being done. Women with a sonographic short cervix less than 25 mm diagnosed in the mid-trimester should be offered daily vaginal micronized progesterone for the prevention of preterm birth and neonatal morbidity. The progesterone formulation, they recommend NMP, either the soft capsules 200 milligram nightly or the gel 90 milligrams each morning. Universal cervical length screening and vaginal progesterone treatment is a cost-effective model for preventing preterm birth. So what is the evidence on which FIGO recommendations for progesterone prophylaxis in women with a short cervix are based? To address this question, it is necessary to consider the efficacy of progesterone, impact of such a strategy on a population basis, and long-term benefits and harmful effects of progesterone treatment in pregnancy. So a prolonged trial was done. published in October 2019, no significant change on the rate of preterm births or neonatal morbidity in the groups comparing the patients treated with 17 OHP against patients giving placebo. Optimum study compared vaginal natural progesterone versus placebo in the outcomes of improving the obstetrical outcomes by lengthening the pregnancy and the neonatal outcomes, and they found to have no significant effect on any of the primary outcomes. Moreover, subgroup analysis of women with a short cervix showed no significant interaction between cervical length and outcome. In other words, women with a short cervix did not respond better or worse to progesterone as compared with any other woman in the study. So there was this progress study, compared the outcome of randomly divided patients managed by vaginal progesterone versus placebo. There was no difference in the primary outcome, that is the incidence of RDS in newborns. So to conclude, the National Institute of Clinical Excellence in the UK, FIGO and SMFM in US all recommend the use of progestogens for women at high risk of preterm birth. The latter advises, that is the Society for Maternal Fetal Medicine, that women between 20 to 36 gestational weeks receive 17-hydroxyprogesterone caproate, 250 milligrams IM weekly, starting at 16 to 20 weeks till 36 weeks, or delivery for women with a singleton gestation and a history of prior spontaneous preterm birth. The two former organizations endorse the use of vaginal progesterone for women with a short cervix. ACOG Practice Advisory, this came out in April 2023. There was not sufficient data to indicate 17-hydroxyprogesterone caproate as an effective treatment in all pregnant women with prior spontaneous preterm birth. Whether this treatment would benefit a subset of women requires further study. FDA decision is not based, however, on safety concern. NMP is as effective. So to conclude this problem, NMP is as effective as cervical cerclage in prevention of premature labor in a woman with singleton pregnancy with a short cervix. Cervical cerclage showed more benefits than vaginal progesterone for women with an asymptomatic short cervix prior preterm birth history, while cervical cerclage and vaginal progesterone showed similar effectiveness for women with a short cervix but without a history of PTB. So if there is a previous history of preterm birth, it is better, and the cervix is short, it's better to give cerclage. But if there is no previous history and just a short cervix, and it seems as if she can go into preterm labor, then it is they are equally effective. You can give either vaginal progesterone or cerclage. Use of MNP is preferable in clinical practice because, as I said before, it's non-invasive, easy to administer, and patients do not have any anesthesia or surgical related adverse effects. Thank you so much.
Thank you, Dr. Ranjana Khanna ma'am, for joining us and that very exhaustive presentation on how to prevent preterm labor, including the evidence-based dissection of which is better, whether it's natural mechanized progesterone, with progesterone, whether it is cervical cerclage, how to actually go about performing a cervical cerclage. In fact, I think in my entire lifetime, I've seen only one rescue cerclage that was performed when I was in Badia 25, 30 years back. It's something which
I put lots of cerclage.
in our practice, usually what happens is patients are put up with a cerclage right at 14 to 16 weeks, textbook style. Very rarely do they come up for rescue cerclage in our setup because we have excellent follow-up most
I
of
have
the
seen
time.
my professor even perform Shirodkar, though I only keep McDonald.
No, we perform Shirodkar routinely, ma'am, in Mumbai.
Okay,
We are very much biased towards
McDonald.
No, they're very much biased towards Shirodkar because this is the birthplace of the Shirodkar
Yeah.
stage. But it took me down memory lane to see how things have evolved. How previously we used to do a history indicated cerclage. Now we are going more into evidence based medicine.
Yes.
We have ultrasound indicated cerclages. And some of the older techniques which were advised are maybe dying away. We are not passing them on to our juniors. But with
Yeah.
senior OBGYNs and reputed teachers like you who are carrying the torch forward, I think we will continue to have a proper
Yeah,
way
I
of
think
teaching.
obstetrics has become a dying art now, is becoming rather.
Absolutely,
We should try
absolutely.
to save it because everybody, all the PGs are going towards reproductive. It's always, reproductive or fetal medicine. That's
Just
it.
couple of days back, I was saying, ma'am, that with IVF specialists creating more and more pregnancies in
Yeah,
high-risk women with lot of comorbidities, many of whom are elderly, and they have silent issues which are not diagnosed. Again, high-risk pregnancy and obstetrics is going to become a super specialty. People like you and I are going to be in demand.
of course.
It's not a dying art. It is going to get revived very soon.
I
Once
hope
all
because
these patients get
it's very,
pregnant.
very dear to me. Obstetrics is my passion, actually.
Absolutely, absolutely. So it's wonderful to have you with us, ma'am. And we had a fantastic talk from Dr. Alpesh Gandhi, sir, as well. We had to switch the order of the speakers because madam was facing some technical issues, but that would have been a perfect progression. You talking about prevention, setting the stage, and then he talking about teaching you.
Yeah.
It was lovely to have both of you today. We have a couple of questions which have come in, but I think they've been answered through these two wonderful talks by these two senior and dynamic proxy vice president and president, respectively. There was one question regarding fetal neurodevelopment and how does smoking and alcohol during pregnancy affect it. Probably this is something which is coming forward more
Yeah.
because in the metros now we find that women are also smoking with the fast changing culture and lifestyle, maybe
Yeah.
alcohol and smoking in pregnancy is becoming more common in the metro cities. So alcohol is well known to be associated with something called as the fetal alcohol syndrome, which results in microcephaly, results in stunted brain development. These babies can also, once they are born, you'll find that their IQs are significantly hampered. And smoking, of course, causes fetal growth restriction. It causes placental infarcts. It can result in sudden IUFDs. All of these issues are quite well known. The second question I see is regarding the ready-made dosage, which Dr. Alpesh Gandhi was speaking. So here I have to acknowledge the role of our educational partners, Listen Pharma. They've come out with a ready-made, easy-to-administer solution, 4 grams of magnesium sulfate in 100 ml, and it's called ID-MAG. It's readily available throughout the country. And even for paramedical staff, where they may have difficulty understanding dosing, dilution, 25% or 50%, how to give, it's very easy. It's a ready-made 100 ml pint, as sir showed in his presentation. You just administer it slowly over 15 to 20 minutes. That's the loading dose, and you can give 1 gram per hour for the next 4 hours, and that covers the patient over the next 16 to 24 hours. It's very easy. You may not even need an infusion pump because administration is so easy, especially in periphery where you get eclamptics. The
Yeah.
magnesium sulfate is still the drug of choice in eclampsia. This is going to be a boon because even paramedical personnel or the doctor is not present in a primary health center, for example, can administer it very easily. That's the end of the relevant questions. I'm very happy to announce that we have an audience of about 900 delegates who are logged in across the length and breadth of the country. So thank you very much, delegates, for being here with us. Dr. Alpesh Gandhi sir has joined in again. Thank you, sir, for being here with us. Any closing remarks, any messages you would like to give the audience before I declare the formal vote of thanks, sir?
Preterm labor is as much a menace for us as it is for the neonatologists because
Absolutely.
they are the ones who have to actually handle the babies. So they are more scared of it than probably us. We try our best. We give antenatal corticosteroids. We try to at least do the lung maturity. And sometimes I've seen that the children don't have to go to NICU at all. So if we have done our bit, then I think it becomes easier for the pediatricians also.
I think it makes their life much easier, and we have to understand that not throughout the
Yeah,
country everybody has good NICU setups.
Yeah.
It's only in metros and good tier two cities.
Yeah, we've got good ICU setups. But if we do our bit about trying to prevent it as much as possible, giving antenatal steroids, giving magnesium sulfate, then I think it makes life easier for the NICU people also.
Thank you. Alpesh Gandhi, sir, any closing remarks, sir?
Always it is important to identify high risk factor, high suspicious, high prediction, high efforts for prevention. So suspicious, prediction, prevention, always very, very important. And the role of for preterm, of course, role Dr. Ranjana ji has nicely mentioned about all the management aspect. But the role of Maxal, role of steroid are very, very important. And again, role of vitamin K. So these all are very, very important. Our job is to extend as much as possible, prolong pregnancy as much as possible. And with all these measures, I think nowadays preterm delivery is incidence is decreasing day by day. But at the same time, the morbidity should not be increased. Morbidity in the sense long-term sequelae should not be there. Our role is not only to see that mortality is decreased. We after giving live child, our main motto should be to give live as well as a healthy child.
And
And
to give a
healthy
good
means
quality of life
physically
to
as
that
well
child.
as physically, mentally healthy mean quality of life. So both the things are very, very important. Our role is very important, significant, and this is not a rocket science, but we need to be we should be alert, we should be updated, we should accept all these newer developments, newer technology, newer molecules for the benefit of our patients and newborns.
Thank you, sir. I think those are very wise words indeed. So I'll conclude today's program, the Fetus in Focus, part of the TOG Experience series, by offering my gratitude to our chairpersons, Dr. Sarita Balera and Dr. Hafizur Rahman. Two fantastic talks by Dr. Alpesh Gandhi sir and Dr. Ranjana Khanna. Thank you so much for gracing the occasion, taking time out despite your busy schedules. I also need to thank the Science Integra backend team, Subhu and Shrutika, who is here. Thank you so much for being there as our scientific support. And last but not least, our academic partners, Listen, who are makers of IVMAG injection I3, that is iron isomaltoside, and Carbacin, that is heat stable, room temperature stable carbetocin for prevention of PPH. Thank you very much for being our academic partners in this journey. Thank you, audience, for logging in. We have over 900 delegates throughout the country. We hope to see you again at the next event very soon. Until then, goodbye, God bless, and bye.